Welcome! Today we're diving into a really critical paper from the one and only Professor Laszlo Tabar and his research team. They're tackling one of the toughest, most persistent questions in modern oncology.
So this really gets to the heart of the problem. We've seen an incredible 50% drop in mortality thanks to modern screening and therapy. That's huge, but the sobering truth is women still die from this disease. This research really digs into the very difficult question of why.
And right out of the gate, in the abstract, they hit you with this this statistic. There's this massive disparity. A specific minority of cancer types, only about 45% of all cases, are actually responsible for the vast majority, 71% of all deaths. That right there tells you we might not be fighting the right enemy. Okay, so to really unpack their conclusions, here's how we're going to walk through their logic. We'll start with that big clinical question, then look at how they completely rethink where these cancers come from. After that, we'll dive into the hard data, go through some really eye-opening case files, and then finish up with their strategies for actually getting better outcomes. So the first big idea here is that the authors are telling us we need to fundamentally rethink breast cancer. We have to look beyond just a single tumor mass. Instead, they say we should be classifying cancers by where they originate, and this is the key part, their growth pattern. This is classic Professor Tabar. Pattern recognition is everything when it comes to predicting what a cancer will do. Okay, so this slide, it's like a visual Rosetta Stone for what we're talking about. Let's just break it down. Over here on the left, you've got the patterns for what's called acinar adenocarcinoma, or AAB. See that star-like or stellate shape, and the more circular one? Then in the middle, we've got these casting-type calcifications. That's a huge red flag for ductal adenocarcinoma, or DAB. And finally, on the right, that architectural distortion, which points to a breast cancer of mesenchymal origin, or BCMO. Tabar's whole approach starts with training your eyes to see these specific, distinct patterns.
And that all leads us to this, which is really the core concept, growth patterns. On the far left, you have a unifocal ASB. That's a single, pretty well-behaved lesion. But right next to it, you see the ones we really need to worry about, the multifocal ASB, the diffuse DAB, and the diffuse BCMO. That's exactly right. And getting this distinction, it's not just academic. It is absolutely crucial. It's the difference between a single contained fire and a wildfire spreading through the forest. And that, of course, has massive implications for how you treat it and what the prognosis is going to be.
All right, let's get into the data now, because this is where the evidence really starts to build and it gets pretty compelling. So these two pie charts, honestly, they tell most of the story. Look at the top two, charts A and B. In chart A, you can see that those combined multifocal and diffuse cancers, the brown sections, they only make up 45% of all breast cancer cases. But then, look over at chart B. They're responsible for a staggering 71% of all breast cancer deaths. The charts below, C and D, just break it down a bit more, showing you how each subtype contributes. But really, the main story, the headline, is right there in those top two charts. Right, let's just pause on that number. 71%. Almost 3 out of every 4 women who die from breast cancer have one of these specific multifocal or diffuse subtypes. It's a minority of the cases causing the vast majority of the deaths. This is the problem we have to solve. And the paper argues that learning to spot these patterns on imaging is the critical first step. And you might be thinking, well, is this just an age thing? Do we just find these more in older women? But what's so fascinating here is nope. Chart A is the main screening group, women 40 to 69. Chart B is everyone else, younger and older. And look at that. The high frequency of these dangerous subtypes is basically the same in both groups. This tells us it's something fundamental to the tumor's biology itself. It's not about when you find it, it's about what kind of cancer it is from the very beginning. Wow, okay, this survival curve, it really says it all, doesn't it? It's just so visually powerful. Look at how dramatically those lines separate. That top blue line, the unifocal AAB, has a really good prognosis. But then look what happens. The multifocal AAB in green is significantly worse. The ductal adenocarcinoma, the DAB in black, is even worse. And then there's the BCMO, that red line at the very bottom. The long-term survival is just devastatingly poor. These are the killers. This graph is the proof. Okay, so we've seen the theory, we've seen the data, now let's see what this actually looks like in the clinic. The paper gives us 3 incredibly powerful case files that really bring all of this into sharp focus.
So our first case is a 35-year-old woman, and this is just a perfect example of why this matters so much. If you look at her mammograms, images A through D, her breast tissue is extremely dense. It's what we call BRAD-C, and honestly, trying to find a tumor in there is like trying to find a polar bear in a snowstorm. But the second you bring in other tools, the whole story changes. Look at the breast MRI in image E. It just lights up with extensive disease. And then the targeted ultrasounds below it, F through J, they start picking off all these little suspicious spots, one by one. The mammogram was just the tip of a massive iceberg. And this is where all that careful work pays off. Up top, in image K, that's a picture of the surgical specimen after it was removed. And below it, in L, is the large format pathology slide. This is a technique that Professor Tabar's group really pioneered, so you can see the whole landscape of the disease. And it confirms everything. At least 7 separate invasive spots, circled there, spread out over a huge area.
Okay, now this is the key takeaway, the part that really goes against how we usually think. The total area of disease here is 75 millimeters, but the biggest single spot is only 11 millimeters. Exactly. So standard TNM staging, which just looks at the size of the biggest tumor, would call this an 11 millimeter T1C tumor. That could lead to undertreatment. But the reality is a 75 millimeter field of cancer. This case proves that for these cancers, the multifocality itself is the real predictor of a bad outcome.
All right, case number 2. This is a ductal adenocarcinoma, or DAB. And remember, this is one of those types that's way more dangerous than it looks. On the mammograms, images A and B, the tissue's dense again, and the only clue at all is a few incredibly faint calcifications. It's so subtle. But then you look at the MRI in image C. It's like flipping on a floodlight in a dark room. You see this massive, extensive disease spread through an entire lobe of the breast, a huge cancer that was practically invisible on the mammogram. The pathology here it's just incredible, and honestly, a little terrifying. In images F and I, what you're seeing is something called neoduct genesis. The cancer is literally building its own new malignant plumbing system to invade the surrounding tissue. And then, in the higher power views, G and J, you can see it using the breast's natural connective tissue, the Cooper's ligaments, as a direct highway, spreading right towards the skin. It's a much more aggressive, invasive process than you'd ever guess from the mammogram. And here's where you see the real danger in action. Image K shows clumps of tumor right under the skin, and L is just a closer look. The cancer used those ligaments like a super highway to spread. This is such a critical teaching point. If you just see some calcifications and call this simple DCIS, ductal carcinoma in situ, you are going to massively undertreat this patient and they will have a bad outcome. Getting comprehensive preoperative imaging like an MRI to see the full extent it's non-negotiable.
Okay, our last case. This is a BCMO, breast cancer of mesenchymal origin. And remember that red line on the survival curve that went straight down? This is it. Now look at the mammograms, A through D. In this dense breast, they look pretty much normal. There's no obvious tumor, no suspicious calcifications. But then we bring in the heavy hitters. The AI overlay in E, the ultrasounds in F and G, and especially the breast MRI in H and I, they reveal this shocking truth. There is a massive cancer taking up almost the entire top half of the breast. It was hiding in plain sight.
So what's absolutely jaw-dropping about this case is what we're looking at here. This is after the patient had neoadjuvant chemotherapy. Image J is the big picture slide, and K is a zoomed-in view. Even after all that powerful treatment, you can still see multiple spots of viable, very aggressive-looking cancer, which are circled in K, just scattered throughout the tissue. The chemotherapy barely made a dent. This just shows you how biologically aggressive and resistant to treatment this particular subtype of cancer really is. Yeah, and these higher power views just drive it home. The aggressive cancer cells are still there. This case is just the perfect, terrifying example of how lethal BCMO is. It looks like nothing on a mammogram, but it's hiding a highly resistant killer. And this just hammers home one of Professor Tabar's central messages, the absolute critical importance of pattern recognition. We have to train ourselves to spot those very subtle signs of architectural distortion, because with BCMO, that might be the only clue we get. Okay, so after seeing all that, which is pretty heavy, the big question is, what do we do about it? How do we actually fight back against these fatal subtypes?
The paper doesn't just leave us with the problem. It proposes some really key strategies to take these findings and use them to directly improve patient outcomes.
So this slide here basically lays out their 6-point plan for how to do this better. It's not just about finding a cancer anymore. It's about fully understanding its personality. Right. The first 2 steps are all about gathering the intel, using these imaging patterns to predict how the cancer will behave even before a biopsy. And then using every tool in the toolbox, especially MRI and ultrasound, to map out just how far it has spread. But steps 3 and 4 are just as important, and they're all about communication. It's about breaking down the walls between the radiologist and the surgeon to make sure the surgery actually removes all the disease, and between the radiologist and the pathologist to make sure what we see on the images matches what's under the microscope. And finally, steps 5 and 6 are about closing the loop. You have to do a comprehensive correlation after surgery to make sure you got it all. And most importantly, the final report has to explicitly state these biomarkers and growth patterns. That way, the entire oncology team knows exactly what they're up against and can make much smarter, more personalized treatment decisions.
And that really brings us to the final and most important question the paper leaves us with. Adopting this kind of systematic, pattern-based approach, it isn't just an interesting academic idea. It's a clinical imperative. Figuring out how to integrate these concepts into our daily work, that's how we're going to start changing the outcomes for women with these incredibly deadly breast cancers.